what do we do with this tumor? Both the patient and I preferred medical therapy for this 95-year-old gentleman. And let's first talk about what was my favorite medication. My favorite medication was topical interferon, which I like to call my angel drop because it was so well tolerated. I give it as 1 million international units per ml. That's the concentration. I give it 4 times a day, and it's an everyday drop. A minimum is really 4 months to completely have the tumor resolve. I have the luxury of the OCT, so I can be sure that the tumor is gone. What I tell others and what we've published on is that if you don't have the luxury of an OCT, once you see that it's clinically gone, you should treat for another 6 weeks with your topical interferon just to ensure that you've eradicated the microscopic disease. You can also give interferon as an injection, which I give as 3 million international units in half a cc. In my original publications, I gave this 3 times a week, which was what and how we treated hepatitis, which was 3 million 3 times a week. People got subcutaneous injections. And that's how I started doing it, just imitating that. But now I do it once a week because they do get flu-like syndrome, feel malaise, sort of COVID-like. So it's different than the drops, which have really no side effects at all. So that's why I call it the angel drop. And it has very high success. In India, you guys use lots of it. And in India, you have the benefit of being a very inexpensive drop. I think Geeta, when she came to visit me, said that it costs $1 or $2 for interferon. But in the States, it's become very, very costly. It's cost we charge $800 per month for the topical interferon. So that is a big drawback. And it also takes a lot of time. I think that it's probably cheaper to go to India and to fly there and stay there and get treated with your interferon there for $1 or $2 than it is to pay the $800 per month. So let's look at some cases with interferon. Here's a patient that I like to show who has a leukoplakic and gelatinous lesion with classic thickened hyperreflective epithelium. And he took topical interferon for 4 months and had a beautiful resolution, which you can then see on OCT. Clinically, he looks great, but you can see that the epithelium is totally normalized after treatment. Here's another patient that had very subtle tumor here, and this would definitely be harder to guess where the margins were when you were doing surgery, which is another great advantage of doing topical medication. So here's the patient, and then here's the patient after 5 months of topical interferon. So because of the costs in the States, my favorite has switched to topical 5-fluorouracil. And this is a drop that is cycled instead of being an everyday drop. And that gives the advantage also, it's easy for patients to do because they do 1 drop 4 times a day for 1 week, and then it's off for 3 weeks. It generally needs 4 cycles. So remember, 4 months of interferon and generally 4 months of 5-FU and not more than 4 cycles of mitomycin. So in the States, this is our bargain. In India, all the drugs really are a bargain, but in the States, the 5-FU is only about $35 per month, and it also enjoys very high success rate. The downside is that it does cause some discomfort, not as bad as mitomycin. So I call this the assistant devil drop, or a lot of our patients speak Spanish, so I call it the diablito, which means the little devil. And of course, compliance is a problem with any drop. So looking at how this works, this is a patient that had a very papillary lesion here. I gave him 2 months of 5-FU, and this is the way his eye looked. Now, remember, I'm going to do 4 months in general, and while I have the OCT that can ensure eradication, I do say that if you are, again, if you don't have the OCT, after you see clinical resolution, I would then give another bottle or do another 2 cycles of the 5-FU just to ensure that every morsel of the tumor is gone. So looking at a tumor that is more extensive here, that's all around the limbus, another extensive tumor. Then here is the patient. In this case, I did 7 cycles. And remember, they're only 1-week cycles. Now, what's my least favorite? It's probably the drug that ophthalmologists are the most familiar with, which is topical mitomycin. And this I use 0.04%. I also cycle it 4 times a day for 1 week only. And then the most important thing with mitomycin topical treatment is that you wait until the ocular surface is healed. I think a mistake that people use, is that they use the mitomycin 1 week on, 1 week off, or when the ocular surface has disrupted epithelium. That's when really the tremendous toxicity occurs with mitomycin or 5-FU. So you need to wait until the eye is white before you can then repeat it. Success rates are very high. In the States, mitomycin is very costly, and I know in India it's also not very costly, but the bottles charge $300, $400 per bottle. You also do need punctal plugs, which is another expense for our patients, and it requires compliance and refrigeration. And it is the worst in terms of side effects for the ocular surface, causing stem cell deficiency, melting. Dr. Mesqua and I just recently saw a patient yesterday with side effects from mitomycin from pterygium surgery. So it's really a devil, in my opinion. So here's an example of a patient that I did use mitomycin for, who had an extensive tumor all over his ocular surface, and mitomycin cleared it up the way I could not with surgery. And then here's a little bit left over that I'm going to need to continue to treat with. Let's go back to our 95-year-old gentleman. So I decided to treat with 5-FU. And remember, I chose 5-FU because in the States, that is the most economical. It's also easy for patients in terms of access to the drug because it's a drug that's given 4 times a day for 1 week, and then they're off, and then they take their next cycle. They can take the drug home, they get the medicine from us, and they can do 2 cycles and not have to order the medication or come back in between. So that's what I put him on, and here's what he looked like after just in this case it was 6, even though usually it goes away with 4. This is a biggie. So I do it until it's gone, and here's his before, and here is his beautiful after picture. How about the OCT? So remember, my high-resolution OCT helps me diagnose and also helps me follow it. So here you see this is the area of the scan. This is the image we saw before with thickened hyperreflective epithelium. And then now after, in the same location, what you're going to see is completely normalized, thin epithelium in the conjunctiva and on the cornea. So this is gone. But of course, medical therapy does take time. So you need to be patient. And I like to say that good things come to those who wait. So when you're going to treat someone with medical therapy, they do have to be compliant and they do have to be patient. So they have to be a patient. Just let's switch and talk a little bit about surgical excision and how I do it. So Dr. Carol Shields has taught us, and we teach a course at the Academy every year on excision of conjunctival lesions, that we are best served by doing wide excision, which means about 4 millimeters if you're able. No touch means that obviously you have to touch the tissue, but you take the area outside where you think is clear margin and then dissect that, and only last do you actually touch where you think there are tumor cells. When I take off the lesion, I orient it on a piece of paper, and this is very important to be able to know that if a margin is positive, which one. So here you see I wrote superior, temporal, inferior, and then this needs to go over in pencil, because once you put it in the formalin, the ink dissolves, and then Dr. Dabovie is able to tell me if I cleared my margins. Absolute alcohol for 1 minute. This helps get rid of and debride epithelial cells that are left. And then I scrape, remove that, and I send these cells all for analysis. I do double freeze, slow thaw, to both the conjunctival margins and to the limbus. And this is my retina probe that I've just taken the sleeve off, and then I put it all as much as I can on for the deep freeze, slow thaw. And then I usually close with amniotic membrane and tissue glue. So what should we do and how do I decide? Well, if a tumor is very large, if it's multifocal, like our 95-year-old, surgery we know is going to cause stem cell deficiency, and I think that it's a good idea to start with medication. Most of the time, as I said, 85% of the time to 100% of the time, you're going to be able to cure the patient with your medicine. But even if not, then you chemo reduce it so that at least you'll be able to do a smaller surgery. Now, if this is a recurrence following multiple surgeries, I also prefer to do medication, but you know what it is, and the patient has already had many stem cells sacrificed or scarring. The real question that you need to explore with your patient is about compliance. If they're not going to take the medicine, then it's not going to work. I mean, you can do injections that ensures that it gets in there, but the patient still has to show up. So if you feel like this is a patient who is not going to show up, is not going to be able to take their drops, then definitely this is a patient who needs surgery. The other thing is that if you're not sure what it is, again, I have the luxury of the high-resolution OCT and I can see classic features. But if there's something that's fishy, something that's unusual, something that I don't like about the OCT, if you have a doubt about what the diagnosis is, then surgery is necessary because it's both diagnostic and therapeutic. If the lesion is stuck or fixed onto the globe, that's also another reason when I prefer to do surgery so that I can do a sclerectomy and get the deep margin. Now, if I'm going to treat topically, what is my choice then? Well, then I do 5-FU or interferon. If money is not an issue, then interferon is my favorite. If cost is an issue, then 5-FU. And so how do I decide? How do I play? Unfortunately, we're not going to be in Las Vegas this year. But basically the factors that I think about are if they can afford, if they can get the interferon, if they're going to be able to keep it cold, and if they're going to be able to put it in. 5-FU has become my go-to drug. It's also, as I said, very helpful because it's becoming difficult to even get interferon. Only certain sites can have it. We make it. So 5-FU is easy. They take the drug with them, and then they can do their 2 cycles before they need to see me again. And also 5-FU seems to work better in patients who are immunosuppressed. So we've published on this because interferon is an immunomodulatory. It revs up the immune system to fight the cancer. We've noticed that in patients with atopy and other immunosuppressive diseases, 5-FU works better. And then my last resort for topical is for the mitomycin. Again, if you start with something and it works, great. And if you notice that then it stops working, there's a plateau, it's always good to confuse the tumor. So this is not common, but if I had a scenario where the tumor was resolving, but there was a little stubborn area that wouldn't go away, then I can either operate or I could just switch medications, and that will often take care of the tumor completely. So in summary then, excision with cryotherapy definitely works, but in extensive tumors, it can lead to stem cell deficiency and recurrences because we can't get every morsel of the tumor out. Mitomycin, 5-FU, and interferon are very helpful. Interferon has been my favorite because of the well-tolerated kindness to the ocular surface in the form of the drop. But now I use more 5-FU because in the States, interferon is very expensive and hard to get. And then sometimes we need to combine modalities. Thank you so much for your attention.